Hi guys, welcome back to my channel and thank you so much for sharing and liking my previous videos. Today I have two special guests. I have Dr. Frederick, who's a gynecologist, and I have Dr. Teresa. You remember her? She's a pharmacist. Today, Dr. Frederick is going to take us through fibroids and tubal factor infertility. Yeah, so welcome Doc, you can introduce yourself.
Thank you. My name is Dr. Frederick Kairithia, gynecologist, based in Nairobi, and it's a pleasure to take part in this talk.
Yeah. Hi, I'm Dr. Teresa, also in Nairobi, and it's nice being here again.
Yeah, so Dr. Teresa, you can just take us through the first part with Doc for fibroids, and then I'll go through the tubal factor infertility.
Okay, so last time we spoke about fibroids, general information, and we got a lot of questions, people asking us, more complex questions. So we decided to involve the doctor who can also, give us more information. So Dr. Kairithia, it was, I think, the same time last year when I came to you with the problem of fibroids. And I like the fact that you took me through the whole process until surgery. Despite the fact that I was a doctor, someone would expect I should know these things, but you really took me step by step.
Yeah.
So there's someone out there, someone who is probably diagnosed with fibroids right now, and the first thing is always to search online and check what are my options, what am I fighting, and then so would you please just take us through fibroids and general information and maybe the treatment options depending on the conditions.
Thank you. So fibroids are basically benign swellings on the wall of the uterus. They are benign because they are not cancerous, and they are quite common. The cause of fibroids is not known, but there are a few theories that try to explain reasons why some people are more prone to getting fibroids, whereas others are not. Being benign in nature, then you understand why they may take a while before they are diagnosed. And some series actually indicate that the prevalence of fibroids in the general population is more in the tune of more than 50%. That means it affects quite a number of ladies, most of whom may not be aware that they are having fibroids. Having said that, for those people who have symptoms, they may manifest with symptoms like excessive or heavy bleeding, which might be cyclic, corresponding to periods. So at the point when they are getting periods, you find the menses are very heavy. And consequently, they present with recurrent anemia, which means low levels of blood, because obviously they are losing excessive. Patients may also present with pain in the lower abdomen, pressure. Some may come with frequent urination because the fibroids, which are swellings on the uterus, are actually suppressing the blood. They are suppressing the bladder, and as a consequence, they tend to urinate quite frequently. Of course, the other thing which they manifest with is pain when having intercourse, what we call dyspareunia. They may also have difficulties in conception because these are space-occupying lesions. So when they compress and distort the architecture of the uterus, it may make it a bit impossible for conception. And those who conceive may tend to have recurrent miscarriages as a consequence. Usually, if they are grossly enlarged, we are able to diagnose through clinical examination, but for purposes of further characterization of fibroids, we subject people to ultrasound or an MRI, and this is necessary also for planning the kind of intervention that you want to undertake. Yeah.
Okay. So for the treatment options, I've just had like people, like there's the surgery that she did. Yeah, so people have always said like if I've done surgery, I shouldn't stay for a maximum of maybe 5 years without getting a baby because there's a risk of recurring. Can you like tell us more about that?
That's more of a myth in the sense that people, you can get, the fact that you get surgery doesn't mean that you just hurry up and conceive. I think more of the anxieties is in the sense that most ladies feel a bit exposed, that they really want to get babies as soon as possible. One of the things I didn't mention is that one of the risk factors for formation of fibroids is staying for long without conception, what we call nulliparity. They are quite rare in people who conceive, who have had kids. So that is more of a myth. Yeah. So, and then of course it's good to emphasize also that we do surgeries based on, or any treatment based on what objective you have. You might find somebody who is in their 20s, early 20s or mid 20s, whose main problem is pain or excessive bleeding, and they're not intent whatsoever to get babies in the near future. So then they shouldn't change their course and start getting babies when they are not ready.
They're not ready.
Yeah.
Okay. And so Doc has clarified, so it's just a myth and it's only in your mind, right?
Because some people say, so I read a lot of posts where people say that no, after the surgery, if you've not had a kid, like in my case, I don't have children, so you are told like, you know, these things can come back in the next 5 years or 4 years or something. So it's something that's very, very common online. Yeah, so you meet a lot of patients that come here with the same problems. Why do you think most women don't like talking about their conditions? And then there's this thing whereby people are really scared of doing surgery. Most people will tell you, no, let's try herbal medicine, let's try, you know, changing diet, but in the long run they don't really go down. They keep on, the tumors keep on growing and nothing much happens. I
think the fact that it touches on the reproductive aspect, it makes a taboo, and people are very reluctant in discussing reproductive matters.
Yeah.
So that explains the common notion that people shouldn't talk about fibroids. And the problem with that is that people suffer for long before they seek treatment, or they go for the very unorthodox kind of treatment, whereas there is treatments which are tested and proven, which can help. Because people will try prayers, they'll try herbs, they'll try nutritional modifications, and all manner of things. But eventually you find the fibroids, what they are doing is just postponing the problem. Occasionally you get remission of symptoms, but after a few months they come back with a lot of force. So surgery, of course everyone fears surgery because it involves a few risks, but these risks also are amplified depending on where you are taking surgery. If you are being done surgery by somebody who is competent and qualified, then you should not worry much.
Okay.
And I've seen like on the internet, there's these herbal remedies that people actually use, and then some people say they use it and then it shrinks. Some people say like they've used it and the fibroids have just fallen off, like the uterus, like it just like pops out. So Can you comment anything about that? Because I'm actually seeing, if you go to Instagram pages, Facebook pages, you can see there's so many like people who are actually coming up and selling this herbal medicine. Some are just like they look like pessaries. So some of them now you insert and then they tell you, I don't know, you do how many cleanses or something of the sort, then you'll be fine.
Such remedies I am not conversant with, but what I know is that fibroids grow within the wall of the uterus. So they are part and parcel of, even when we are removing them, we have to cut through the wall of the uterus to access the fibroid and remove, and then repair the place where the fibroid was sitting. So then it makes sense to say that it is not possible for these things to fall off because they are not just hanging. Secondly, they are not hanging. They are just part and parcel, so they have to be removed physically. You talked about some remedies which shrink the fibroids. It is possible to shrink because fibroids are heavily reliant on hormones, especially the estrogen. So any remedy that blocks estrogen will shrink them, but that's a temporary relief. We actually, one of the methods we use to treat fibroids is to block estrogens temporarily, especially when the patient is not ready for surgery, or they are not fit for surgery, or they don't have resources to undertake surgery, or they are bleeding heavily. So we use that as a temporary relief as we prepare for the definitive treatment. And there are three types of treatment that we give definitively. One is to remove the fibroids through surgery, like what we did on her. The second approach is to block the blood supply to the fibroids. We do something called uterine artery embolization, and you're trying to block the blood supply to the fibroid so that they shrink. The third approach for ladies who are postmenopausal or they are no longer intent on conception, we actually offer removing the uterus as an option. So we do something called hysterectomy, either through the vagina or through the abdomen, what we call transabdominal hysterectomy. Of course, you're also aware that doing nothing is a form of treatment, especially if the fibroids are stable, they are not causing symptoms, or they are too small.
And you mentioned that they cause miscarriages, right? So like if someone has like fibroids and they're causing like frequent miscarriages, and I've had people say that when you have fibroids and then you actually get pregnant, they shrink off. Does that really work? Is that applicable?
They don't shrink because fibroids are they are swellings. They are quite compact swellings on the wall. So what happens with the pregnancy? It can either take the route where they flatten out and become asymptomatic. But for majority of ladies, you find because there is interference with the blood supply, they undergo a process we call degeneration. They cause frequent pain, they can cause premature uterine contractions, and hence that's how they cause miscarriages. They can cause bleeding, they can cause abnormal attachment of the placenta so that the pregnancy does not grow. And they are the commonest for women who conceive with fibroids. They end up with the preterm deliveries, which can either be spontaneous or those deliveries which are induced in the interest of saving the baby or the mother. So we call them iatrogenic prematurity.
So I think that's it for fibroids, Or if you have anything else you can add, if you want your viewers to know anything more about fibroids, you can add. Or Teresa, do you have anything?
I wanted to ask, how often, right, since statistics says that 80%, 70 to 80% of women at one point in their lives will get fibroids.
Yeah.
So how many times should, like how often should women maybe just do a scan to check, just to be on the lookout?
We are encouraging annual medical examinations, and an ultrasound should be part and parcel of that. However, it depends. If you've been diagnosed with a fibroid, we do tracking to see whether they are growing in size. Are they increasing, or they are still they are not increasing in size? So that one will be the frequency will be guided by the person who is following you up.
Okay.
Yeah.
And we spoke about surgery. So okay, so after surgery, is there like a diet to watch someone should do, or you just live your life normally?
You live a life. Your
Yeah,
life
I live my
normally.
life normally, but
because
someone
the problem has been solved. The only time we talk about diet is if you're talking about iron-rich diet to replace blood that you lost. But generally, there is no diet restriction. Yeah.
And you don't do like hormonal therapy, since I've seen like it's more of estrogen dependent. Estrogen is the one that like
increase
growth.
Yeah.
So after surgery, is someone put on any hormones, or can someone actually be put on drugs that actually stop estrogen production and not go for surgery, and then it will help the fibroids like to degenerate or shrink?
That is usually a temporary measure, as I mentioned, for patients who are not ready for surgery. Either they don't have time for surgery, they have other medical conditions, so we say they are not medically fit for surgery, or they don't have resources, or for one reason or another, you do not want to subject them to surgery. So you'll suppress the hormones in the interim as you wait for circumstances to change for you to do the surgery. There are women who will bleed when they are about to go into menopause. Those ones you can suppress and give them what we may call terminal suppression of hormones, because eventually when they go into menopause, the estrogens drop, and therefore most of them you find the symptoms disappearing. Yeah.
Okay, fine. Yeah, so it's like the ultimate solution for fibroids surgery, right?
Not necessarily. Not necessarily.
There's the watchful waiting, depending on the size.
Yeah.
I think, like he said, depending on the sizes, the bigger they
the
get.
size and the number.
Yeah.
And the symptoms. Remember, we say up to 80% of women have fibroids, as she said. So if you are to operate on anyone with a fibroid, then you will end up operating everyone. Yeah? And as a matter of fact, everyone will get fibroids, whether they have symptoms or not. Almost everyone. So we select those who need surgery, those who need drug treatment, and those who need just watchful waiting, meaning doing nothing. Yeah.
Okay. So anyone out there who is scared to do surgery, I think that clarifies it. I did my surgery and I feel much better, and yeah, the symptoms I feel really good after the surgery, so there's no need to be scared or worried. Yeah.
So we can quickly transition to tubal factor infertility. Yeah, so we can just begin, like you tell us more about tubal factor infertility, the causes, the treatment, and then that's it.
It's a wide topic, so I'll try and just simplify and condense it. One, the fertility, especially among ladies, is dependent on a couple of factors. One, the structure of the reproductive tract. And secondly, the functioning of the reproductive tract. Functioning means they have adequate levels of hormones and they're ovulating. But for them to conceive, then they should have a structure which is which allows that. In the previous talk, we've talked about fibroids and how they compress and distort the uterus. And remember, the uterus is where the baby grows. So with that distortion, then it means that it's a hostile environment. So tubal factor infertility is a scenario where the fallopian tubes, which are two, one on the left and one on the right, have some form of blockage. Okay? The function of the tube is actually to act as a conduit and enable the egg and the sperm to meet. So fertilization takes place within the fallopian tubes, and then the embryo migrates into the uterus where it is implanted. So what it means is that if there is a blockage within that passage, then it is impossible to have either the egg and the sperm meeting and fertilization to take place. Yeah. Some of the causes of tubal blockage: one, it's infections. Yeah, infections can cause scarring of the tubes, especially what we call pelvic inflammatory disease. Fibroids can also encroach and suppress and compress the tube. They cause kinking by applying mechanical pressure on the tube. Then you have other infections like TB of the pelvis. Any surgical procedure, if it heals and causes adhesions, you can get interference with the tubes. Okay. Yeah. So those are the common causes of tubal blockage, and of course, inflammation from conditions like endometriosis. Yeah.
Okay. Can like STIs cause that, like chlamydia, gonorrhea?
Yes, STI. When I said pelvic inflammatory diseases, loosely it also includes that, because these STIs will cause a lot of inflammation, then healing with scarring. And remember, the tubes are very small in caliber, so that scarring will cause the blockage. Yeah. So anything that interferes with the tubes will cause physical occlusion in the lumen or in the cavity, and therefore there is no communication between one end of the tube and the other end of the tube, which opens into the uterine cavity. Yeah.
So just one question: if one part, okay, like if I understand, like we females have like two fallopian tubes, right?
Yeah.
So if one is blocked, can someone conceive using the other fallopian tube?
The answer is yes. It's possible to conceive with one fallopian tube, especially if the remaining tube is normal.
Yeah.
The only issue is if the tube which is removed, or the damaged fallopian tube, happens to be the only tube which was functioning. Yeah.
So what are the symptoms? How can someone know?
Yeah, that they have blocked fallopian tubes.
Actually, it's not. There are no symptoms that you get with the blocked fallopian tubes. We discovered them after we do a test called HSG, which is hysterosalpingogram, and it's one of the modalities we use to investigate the female infertility. And the principle is you put some dye through the cervical canal, which ultimately is supposed to spill, to go through the uterus, the tubes, and then spill. So if there is no spillage, then we conclude that there is some blockage somewhere. Yeah.
Okay.
And so if someone has, so you've done the investigations, you found someone has tubal factor, like it's blockage. It's blocked. So how do you go about it? What are the treatment options for that?
Depending on the level of blockage, a typical fallopian tube has got 5 parts. So there is the part which is closer to the uterus, which we call the conio end. and then the farthest part is called the fimbrial end, which has got finger-like projections. So if the blockage is towards the head, there is a probability that it can be unblocked surgically. But if the blockage is either in the middle or towards the end of the uterus, towards the point where it attaches to the uterus, then it's not possible to unblock it. So now we explore other alternative, what we call assisted reproductive techniques. And here I'm talking about IVF, whereby you're trying to bypass the blocked part by obtaining an egg from the female and a sperm from the man, achieving fertilization outside the body, and then implanting the embryo to grow in the uterus.
So there's a point in which it's reversible, and then another point it's completely irreversible.
Yes, depending on the assessment. When you do the test, the scans and the HSG, you're able to tell whether it's worth trying, or if you go ahead and explore other modes of conception.
Earlier on we had talked about ectopic pregnancies. So ideally, what I understand, it's like instead of the embryo moving to the uterus, it actually remains in the
tube.
So is there a risk, are there risks for ectopic pregnancies, and how they can affect future fertility?
I mentioned that fertilization takes place in the fallopian tube, and after that it's supposed to migrate gradually and get implanted in the uterine cavity, the endometrial cavity. That means if there is a delay in that migration, then the embryo ends up implanting in the fallopian tube. And the caliber of the fallopian tube is so small such that within the first 5 to 6 weeks, the fallopian tube will burst, because the pregnancy is increasing in size. Then there is the action of the placenta, so the fallopian tube will burst and cause a lot of bleeding, internal bleeding. So you asked whether it has effect in future fertility. Obviously, fallopian tube, ectopic pregnancy in the fallopian tube causes damage to that tube, and inevitably, if the tube is damaged completely, then it is removed as a way of treating the internal bleeding. So consequently, you find somebody is left with one fallopian tube. So they are working on 50-50 basis, assuming that the remaining tube is okay. So of course it has an effect on the future fertility.
And does tubal factor infertility have a thing to do with ovulation? Will it stop ovulation? Will it prevent ovulation, or someone will have their regular cycle?
It doesn't. Ovulation process is independent of these other factors, because as long as the ovaries are there, and then the egg is maturing and then getting released, that's what we call ovulation. Such that even ladies who have had their uteruses removed and the ovaries left, they still continue ovulating.
Okay. No, I'm good.
So thank you so much. I think that's it.
You're most welcome.
Yes. For further consultation, if you would like to consult him, I think it's best he tells you where he's located, so that if you have any gynecological issue or disorder, you can always get him.
So my office is in Hurlingham at a building called APA Arcade. I'm on first floor, suite number 9, and you can also get us on phone. That is 073922 5565. Thank you.
Okay, so thank you so much, guys. Make sure you give this video a thumbs up and make sure you subscribe to my channel and share the videos with others. Thank you. I'll see you in the next video.
Thank you.